organizing committee asked me to start off this session on war because we actually did a lot of work a long time ago in the first Gulf War. So I'll start by telling a little bit of a story. Almost exactly, I'm old, you can tell that. About 30 years ago, almost exactly 30 years ago, I was about 4 years into being a new faculty member at Georgetown. And I was becoming a bit of an expert in fibromyalgia because no one knew anything about fibromyalgia. And most people didn't believe it was a real entity, that they thought these people were just making this up. And I got invited to give medical grand rounds at a hospital in West Virginia, in Martinsburg, West Virginia, and I accepted the offer. I didn't have any idea what I was getting into because it turned out that this hospital only had grand rounds every 3 months. They had a huge crowd, but the person that they really wanted to come to see was the person that was speaking after me. They had two speakers at the grand round. So I get up and I give this talk on, 1994 talk on fibromyalgia. The next speaker is the Surgeon General of the Army in the United States. And he is coming to talk about the health consequences in the veterans returning from the first Gulf War. And he gets up and he's like, the average general with medals all over, like all over his chest, and he gets up and he says, Dr. Clauw just explained all the symptoms we're seeing in the returning veterans from the war. And he then invited me to speak. I probably spoke 8 or 10 times before congressional committees, presidential committees involved in studying the health consequences of, now remember we're talking about the first Gulf War, where there was actually not much of a war, but there were a lot of the veterans, not just from the United States, but from a number of other countries that were coming up with sort of otherwise unexplained symptoms. This was first called Gulf War syndrome, and later we changed the name to Gulf War illnesses because it became clear that there was nothing unique about this syndrome. You saw this over and over and over again in different settings. And so these are literally 25-year-old slides that I didn't have to change hardly at all, talking about what we learned about the Gulf War. Again, a lot of individuals were deployed. There were very few combat casualties in this war. Remember, this is a war where it was mainly a war fought from the air. There was no ground combat. There was almost no PTSD after the first Gulf War because the soldiers weren't directly seeing other people getting killed and things like in the subsequent conflicts in Iraq and Afghanistan and all the other wars we fight. But these individuals were coming up with multifocal pain, fatigues, memory problems, sleep disturbances. The way the US dealt with this initially caused a lot of problems with the veterans because for the first 2-3 years, they denied that these symptoms were real. And basically, when these individuals would go to the military providers or to their to the DoD providers, they would basically say, "There's nothing wrong with you. We do all these tests. There's nothing wrong with you. Suck it up." And the veterans groups became very distrustful of the way the United States was responding to this, and because of this, all these conspiracy theories about all these different exposures that occurred in the theater of operations. That's what they call war. When it doesn't sound as bad, theater of operations, rather than it's war, it's bad. All these exposures, depleted uranium, all these things that people thought like caused it instead of like, no, this is just what happens when you take a group of people and you deploy them to fight. And so, again, these slides are 25 years old. We know now that the symptoms that the Gulf War veterans developed are exactly the same as symptoms that are commonly seen in the general population. These symptoms were about twice as likely to occur in people that were deployed to the Gulf. The same symptom complex as the general population, but being deployed dramatically increased someone's risk of developing those symptoms. A CDC study that was done, the CDC was involved. They did a number of studies, and what they called this cluster was chronic multi-symptom illnesses. Again, multifocal pain, fatigue, memory problems, sleep disturbance, and psychological abnormalities. This is an old slide. A lot of these individuals, this overlaps a lot with terms like somatoform disorder, chronic fatigue syndrome, fibromyalgia. Exposure syndrome, I just use that term, is when people think a specific exposure might have led to this illness, and this happens over and over again. Women with silicone breast implants that have been led to believe the implants are causing them problems actually do develop conditions like fibromyalgia at higher rates. And some of these exposures actually do lead to a higher rate, like, again, being deployed to war. This was a really important article that appeared as we were studying this. Military historians, you would think if they're military historians, they should know military history, but they didn't know that after every war the US had ever been involved in, the exact same symptoms had occurred over and over and over again. This was called soldier's heart after the Civil War, because in the 1860s, we thought the heart was the center of the body, not the brain. And it was literally called soldier's heart because of all these protean manifestations that had to be cardiac, because that was the way that we thought of the body at that point in time. But every war, not just the US, but they looked at wars that other countries had fought. I think you're going to talk a little bit about this, Kobe. Over and over and over again, the exact same cluster of symptoms developed in the people that were deployed to war. And so, again, this is an old slide, but it hasn't changed much. We know that infections can trigger what we now call nosoplastic pain. Physical trauma can, psychological stress, and certain catastrophic events. And there were a lot of committees and scientific organizations that looked at these different terrorism, war, and things like that. And there were actually some patterns that seemed to develop, is that natural disasters didn't usually lead to a lot of increase in these types of syndromes. They led to PTSD and things like that, but man-made disasters did. And so as the war was further and further behind us, some of us were still writing articles about it. This was an article I wrote in the British Medical Journal, basically saying that what happened in the first Gulf War it has broader implications about health than just war, because we see this over and over and over again. And people in the military sort of then began to acknowledge this is the older term, central sensitization, that's now been replaced by terms like nosoplastic pain. But these pain syndromes that are originating more from the central nervous system, again, occur fairly frequently in individuals that are deployed. The group of veterans from Iraq and Afghanistan, from the second set of wars we fought in that region. Now there was something called the polytrauma triad, where people develop PTSD and pain, and I forgot what the third part of the triad is, but it's just, these people are just a mess, unfortunately. But again, this is very common in the veterans now that are being seen in our VA and our DoD systems. This is a fabulous article that just came out. There's actually, if you go do a PubMed search on the health effects of war, there's actually very little that's been written scientifically about this. This was actually a really interesting article. It just came out in the lay press. I really enjoyed it a lot. And it pointed me to a website that's at Brown University that basically talks about all the problems associated with deploying people to war. It's called the Cost of War Project, a great website if you're interested in this topic. But in this website, they talk about a lot of these problems. They talk about how these problems are sort of largely invisible to those of us in the general US population. If you haven't had someone that you know that's been deployed to war and ended up like with severe physical or mental health problems, or ended up committing suicide or something like that, you aren't really aware of how many people in the United States have been affected. And again, now I'm talking as someone in the United States. In a minute, we're going to talk as global citizens about around the world, all the wars that the US starts that cause all these problems, both at home and abroad. This is an incredible statistic. There were 7,000 individuals that were actually killed in action in the wars that we fought in Iraq and Afghanistan, but there have been 30,000 individuals that were deployed to those wars that have committed suicide. So this is a huge problem that lasts forever in these individuals that have been deployed to war, this risk of mental and physical health problems. And this is, in this article, they talk about pain that is difficult to trace, and they cite a series of articles that several of us were quoted at. Nick Kristof, who's a writer in the New York Times who writes very elegantly on a lot of different topics. He's written about these deaths of despair that are occurring in the United States, where, again, a lot of individuals, many of them veterans, but other people that have lost hope and have despair, that they have very high rates of pain, have very high rates of suicide. And so we know that you can't always see pain on an X-ray because it turns out that about 10% of people with severe knee pain have an X-ray like the one on the left, and about 30 or 40% of people with severe osteoarthritis on X-ray like the right don't have any pain whatsoever. And most people are unaware that chance meeting that occurred between myself and the Surgeon General of the Army 30 years ago really helped fibromyalgia research, because we ended up getting about $20 million in DoD funding. And in those, the first fMRI studies that our group published in fibromyalgia, they were done as part of that funding, and they were done, fibromyalgia was being used as a positive control group, and we were basically showing that Gulf War illness looked the same as fibromyalgia on brain imaging, and both of them looked quite different than healthy controls. But that single first fMRI study that we published on fibromyalgia in 2002 that Rick Gracely led actually helped convince the FDA that fibromyalgia was real. It really turned the corner a bit, even though all that really showed is that these individuals were really experiencing pain, because with light intensity of stimuli, we were seeing that they were having activations in brain regions like S1 and S2. But again, until that time, and until being able to use techniques like functional neuroimaging, individuals with these conditions were often not believed that there was anything wrong with them whatsoever. Now, and I'll talk about that tomorrow, fibromyalgia come a long way. Now we sort of acknowledge there's a third mechanistic descriptor of pain. It's called nociplastic pain now. And again, I'm sure people will talk about that over the course of the conference. Again, this third mechanism of pain, the pain seems to be coming more so from the central nervous system. You need to use entirely different treatments to treat this kind of pain, especially the drug and treatments are the opioids, nonsteroidal anti-inflammatory drugs are not going to work for this kind of pain. We're going to talk a lot more about that over the next couple days. Again, the new term is called nociplastic pain. Like it or not, we didn't like it, but we're living with it. And this is there's a couple figures from a recent review in Nature Reviews Neurology that Chelsea was the lead author of. This is a cool figure that I like, but talking about all the different risk factors for nociplastic pain, and you see both in childhood and adulthood, physical injuries, trauma, adverse childhood experiences are amongst the risk factors that we're well aware of that lead to this type of pain.